Susan said, I asked her for a little bio, and I've worked with her for a number of years, 16 years actually, at the hospital where I'm a board member. She was raised in Elkhart County, attended DePaul University in Greencastle specifically for research, cell biology, spent time at Eli Lilly in neuroscience drug discovery, St. George's Hospital in London for clinical genetics, and worked for a small biotech firm in Cleveland, Ohio. She returned to Indiana to complete a master's in health administration down at IUPUI, and there was connected to an opening at Goshen Health and has been back in this area with Goshen Health for the last 16 years. She held a variety of roles, starting with a special projects for the CEO, then assistant vice president, strategic planning vice president of cancer services, then vice president, cancer services, strategic planning and marketing. The task got bigger and bigger. Then I think took a brief break and is now vice president of population health and business development. She gave a report to the board some months ago that I thought would be of value to a class like this. Uncle Sam requires that health systems do an assessment periodically of the health needs in a community. And this report then provides the basis for today, telling us a bit about what they discovered on the most recent health needs assessment. Susan, thanks so much for giving us a Sunday morning, and welcome.
Thank you, Del. Good morning.
Good morning.
I'm pretty naturally loud, so I'll apologize in advance to anyone who happens to be on the Zoom. I lost my page here too. If I get kind of loud, if you can't hear me in the back, do one of these, I'll get louder. I've had a lot of coffee this morning. We're gonna do great. Let me get back in here. Great. Del, thank you so much for that warm welcome. I have to tell all of you, it has been a joy working with Del over the last 16 years. I am a naturally curious person. Spending time with someone who studies economics, which is really ultimately curiosity about how people make choices around value, has always been something that I find special. So I've really enjoyed every minute I've had to spend with Dr. Good over the years. All right. I'm just going to click this button. Okay. Thank you, John. It did. It moved. We do use a lot of Zoom at the hospital, but it does look different everywhere you use it. All right. If I can get this to, there we are. Great. As Del mentioned earlier, I'm going to walk through a little bit of the background. I don't want to spend a lot of time on it because I think the content is what's interesting, but I do want you to understand kind of some of the why around why we do these particular community health needs assessments and a little bit of the structure around it, because they are a fairly rigorous platform that are required. So I'm going to touch a couple of those requirements just so you can see how they're built, because how they're built ultimately is going to take us down the path of why we end up with the results we do and how we take those on to benefit the institution and the community at large. So I'll walk you through all of that. Del mentioned that these assessments are a requirement, and it's true. But I would point out that doing a full review of your community tells you a lot more about your community's health needs than simply being in the service of healthcare. Okay, being in the service of healthcare simply means when someone has a need that's egregious or specific or something they personally feel is concerning, they bring that concern to you. So we only get to see that part of our community. If we don't spend time understanding what the bedrock and foundational aspects of health are in our community, we can't work to get ahead of what those needs are and truly influence improvement in a more a more broad and global way for all of the persons that we can choose to serve here in the community. So this is something that we have done for years. We've done it in a number of different avenues at Goshen Health. This is the, I think, fourth one that I've done or been involved with. We do them every 3 years. That is a cadence that is required by the IRS. They also like to tell us about some key pieces they want involved. And that's actually important and useful, because that means that when we look at community health needs, and Elkhart General looks at community health needs, and Memorial of South Bend looks at health needs, because we all need to do this. We're all using some of the same definitions, and that also allows us to partner from time to time when we have some shared needs that maybe we can impact differently as a group. Okay, so that's actually quite helpful. It is related to our tax status. The standards change from time to time. They've not changed since 2014. I do find it interesting, and I would mention it here, if any of you are following some of the current administration's interests. They're starting to talk a lot more about health equity, which I find very exciting, to be honest. Health equity and your community health needs are always going to converge to a degree, because having an equal access to good health care should be a part of supporting your community, okay? They have not formally connected those two agendas, but I suspect they might over the next couple of years. So that's something, if you're interested in policy, to maybe be looking for. The way that these plans are handled, we don't do them in an isolated box as a healthcare system, okay? Our board, as Dr. Good mentioned, is involved and engaged. They actually approve the process, approve the content, and approve the priorities that come out at the end. But beyond that board, we actually work directly with community leaders in the interpretation of the data we collect. That's really important, because all of our community leaders see different parts of the community at a different depth than we do as a healthcare system. And the first way we can move forward in learning is to understand the things we don't know. That way we can ask better questions. So you can see here, yes, there's members of Goshen Health involved, but the Community Advisory Committee, or CAC, it's made up of a number of our partners. This is who was on our board this last time. We rotate this every 3 years when we do it. So we're always looking to engage our community in a variety of ways and with a large number of leaders. So this group is going to go through the priorities I'll show you here in a moment. So they took on the hard work and a lot of hours to look through the data we pulled together and to help us determine its value in our community. Okay. This is a lovely graphic that just takes you through some of the process pieces. I won't walk you through this outside of to say we collect both primary and secondary data when we get started. And then we do an analysis of that. We use a third party. We use a group called Venture Internationals, who some of you may have worked with in the past. They help us with analyzing our data. That way we know it's been done in a way that's non-biased, okay? And then we take all that data to that group you just saw, that Community Advisory Council, and we plug through it and we ask questions and we think about what we see. We then prepare a report. Our Community Health Needs Assessment Report is available on Goshen Health's website. I always encourage people to use it. There's about 200 pages of data and content there. It's a wonderful resource for other nonprofits in our community that are working to engage because they may not have access to the type of support necessary to build that kind of data set. We have it, it's available. They can use it anytime they want to. So that's out there. After that CAC group has identified our priorities and we take them to the board approves them. The health system then builds an implementation plan around those pieces we feel we can move over a 3-year period. So that's our process. We underwent this in 2021. The data collection was complete and approved at the end of the year. And then our action plan needed to be put in place by May of this year, and our board approved it in April. So looking at our data sources, just again, to give you a sense for how do we get information on us, on Goshen and our service. We look at a 4-county area because that's who Goshen Health serves. Secondary data is data that comes from large data sets, right, that are collected by usually government entities. They may come through your Census Bureau reporting, different state data sets. The key pieces that we used here, and I want to highlight one of them, we use the County Health Rankings data set. They have the national data set housed at the University of Wisconsin. It's publicly available. You can go on that website anytime you like. They're a great source. We used to also use Indiana's. Indiana has rolled everything up to Wisconsin like most of the United States has. They've got a really robust platform. We look at some trending data that we create through some Indiana-based sites. And then the new piece in 2021 that I'm going to draw them out a couple of times because the data was extremely valuable, is the United Ways, United for Alice 2020 national and state reports. So if you're not familiar with ALICE, ALICE stands for Asset Limited, Income Constrained, Employed. So this is the United Ways designation of people that live in what is sometimes called the gray. They make money, they're employed, but they're barely getting by. Okay, their needs are very different and they're very sharp and they're not well studied. So the United Way over the last 5 years has spent a lot of time and effort building infrastructure around understanding that community. And we have a large community of that space here that we serve. So those reports were wonderful and their fingerprints are throughout our report here. So that's some of the secondary data. Primary data is data you get from talking to each other. Okay, that's data you get from the primary source of information. So in that case, we do group setting, interviews. We really focus for primary data on our underrepresented or quiet groups in our community because we need to draw their voices forward. So we work with Goshen Community Schools with our Latino and Hispanic population because they've built a wonderful community connection with that part of our community here. We also do specific work to ensure that we've included the Amish because Goshen absolutely serves the Amish and we need to be sure we recognize and understand their needs and how they may be different than other parts of our community. Any question about that? Makes sense? Okay, so a couple points of interest as we went through our data sets. I'm going to start taking you through the results here. With those focus groups, and when we look at special representations of our community, we found that Latino and Hispanic guardians, as compared to non-Hispanic and Latino guardians of children in the Goshen Community Schools, they're pretty similar in their concerns with a couple of specific differences. Health education, diabetes, treatment and prevention, and use of tobacco and smoking were much higher ranking with Latino and Hispanic families, whereas non-Hispanic and Latino families were far less concerned with that. That's interesting. It tells us a little bit of something about that community and how they live, okay? Very interesting. When we went further and dug into the community members outside of the school-aged guardians group, poverty and diabetes were the two very high pieces for our Latino and Hispanic community versus non-Hispanic Latino community. They were a little more interested in physical fitness and exercise being a concern. So again, you can see that while these communities live together, what they worry about is different and what their concern areas are is different. If you're not familiar, this came out with some of our other information. I know there's been some great research at Goshen College in this space. Diabetes is far more prevalent in the Latino and Hispanic population, and the cost of insulin being so high is deeply detrimental to that community. This is something that is actively talked about within those groups all the time. It is a dramatic issue. So seeing this here simply let us recognize and raise up that concern, right? Also an interesting point, this has happened in several of our surveys over the years. The Amish community has a deep-seated concern around violence, and that's violence in the home, okay? We don't see that in our other communities as surveyed much, but it has been called out consistently in that space. So again, as we recognize and want to understand our community and what their needs are, this is one that we've kept an eye on.
Are you talking about family violence, or are you talking about violence from the outside towards the
So the survey that we did this year didn't give us enough data to speak into that. The one that we did 2 cycles ago, and part of it's because we did this in 21 and it was COVID. So we worked just with the leaders. When we did this in 2018, we actually did a small group of women. They allowed us to talk to a group of the women and a group of the men. And at that time, they confirmed it was in the home. Great question. I can't tell you if that's changed. That's what I know. Other questions? That was a good one.
I suggest you repeat the question for the Zoomers.
Ah, yes, I'm so sorry. I will do that. Will you see if there's questions that pop up in the chat, John? If you flag me, that would be great. Please, if you're on Zoom, please just type your questions and we'll make sure we cover them.
Just repeat what the doctor said.
Right now. So the question I just answered was, do we know if the violence that the Amish are concerned with is coming from outside communities or domestic violence within the home? So that is the question I answered. So when we compressed all of that primary data, so the data people talked to us about and shared with us through personal surveys, this is the list that came forward. This is not in any particular order. You can see violence, as I mentioned, with the Amish community, that's here, but cardiovascular health, poverty, diabetes, substance abuse and addiction, mental health, certainly. So this is the list that came forward. Then when we move into our secondary data, and this is just a slide from some of the data that the United Way documentation gives us. I like this just because it gives you a color-coded map of the entire state to give you a sense of what our community might look like. They have set up a designation. If you look at the table for households, and I've got the 4 counties that we serve listed. You've got the total number of households, and then they break households down to those that are at 100% or less of the poverty line. And then above 100% to about 400% of poverty is considered ALICE. That's your asset limited, income constrained, but employed community, okay? And then you've got the percentage that are above ALICE. These are people that you would say are probably not living paycheck to paycheck, or if they are, they're still very comfortable in that process. So what you'll see here is the percent of poverty. Elkhart County is certainly higher than the other counties that we serve, but that percentage of ALICE, it was really quite eye-popping to see 29% in LaGrange County. So that was quite interesting to us. So these are folks that they're employed, they're working, but they're really struggling to keep food on the table. They're struggling to have enough income to pay for their medications if that's something that they need to do. They are struggling, and it may not be obvious to the outside person that they are, because they have jobs, they're working. Okay, makes sense. So I want to take you through a series of trends that came out of the secondary data. Again, that's large, broad data collection that comes forward. This is my favorite part, to be honest. I enjoy the individual and the one-on-one information we get, but seeing directional activity in our community is really helpful when we're looking at having been at the health system for 16 years, because you're going to see some trends that are moving the right way and some that aren't. So these are negative community trends. So these are unfortunate situations that are increasing. So you can see, I won't read this through to you, but child mortality actually surprised me a little bit. During our last survey, infant mortality was moving up, and that was disturbing, specifically in Elkhart County. And if you work with the health department, you may know that, and Goshen supported this, and so did Elkhart General together. We all poured financial resources into the health department about 4 years ago to help them with infant mortality. That trend has been changed, which is wonderful. Now we have a different one. So that child mortality always strikes me, maybe because I have 3 kids at home. Physical inactivity is growing, self-reported mental health days being poor. Again, if you think about the time of this survey, all the data, you're looking at us moving into a pandemic when everyone was told to stay at home. So some of these trends make a lot of sense, but they were helpful to see. So these are some of the ones that are troubling. But we also have really positive trends happening as well. And I like to share that side of the balance sheet. Positive community trends, things that are increasing, college education, wonderful. Ethnic and racial diversity, that is a joy. I love to see that. That makes us a richer population. Household income's been going up, which is interesting when you look at those ALICE numbers, right? Decreasing trends that are positive. Tobacco use and smoking is going down. Unemployment, well, that's way down. We all can't find people to work at this point. But food insecurity going down as well, which is tremendous to see. Questions about any of this content? Another way to look at some of these trends that we considered and brought into our analysis is, this is the health factors data that comes out of University of Wisconsin. So you can select a county or a series of counties, and it'll show you what factors are improving or worsening. So this is another nice way that's directional to see. So you can see adult obesity I'm gonna point that one out. This one. Adult obesity is going up, and that's a bad factor. Okay, so it's one that you can see. Sexually transmitted infections have been going up over the last several years as well in our community, versus teen births, which have gone down dramatically, and that's a great trend. Okay, so it's just another nice way to process the information. When we pulled all this data together, and that small group, that community-led group with Oaklawn and Goshen Community Schools and Goshen Fire Department all involved, that group sat down and pulled this data together, and this was the cohesive list of topic areas that were health needs for our community as of 2021. I'm not going to go through this list with you. I do want to point out a couple that I pulled it. Those were new. Okay, when you look at a community's health over decades, you don't see huge movements. Okay, it's very hard to impact an entire community. It's a little bit like boiling the ocean. But you can improve it, and you need to be dedicated to it. Things that were new included advocacy for seniors. This is huge. You're gonna hear me talk about this some more. Air pollution. This one stumped us. So Dr. Stephen Harmon from Maple City Health Center was a part of our group, and he was the one that drew this out in our group. He said, whoa, I haven't talked about air pollution in a very long time professionally. But we sat and we talked about it. When you think about all these RV companies getting bigger and manufacturing coming in, and now Amazon's building a great big building on the north side of Elkhart, the amount of through-going traffic in this county has doubled and tripled. Whether it's a train and you're late to church, or if it's just the semis that are coming through and all the, tractor trucks pulling RVs, taking them to different locations. So the more we thought about it, it kind of blew our minds that this isn't something people are talking about. So that was interesting. Disinformation about health issues due to political polarization. That's a new one. We didn't talk about that in 2018, but we definitely talked about it a lot in 2021. Not necessarily something we felt we could impact, but it was something we wanted to be sensitive to and draw out. And then the last one that we bolded here was social isolation. And again, going through a pandemic and telling everyone to essentially shelter at home and cover your face when you're out, that impacted our mental health, but it shut us down to social isolation that may have happened and may continue afterwards. So that was something that came out of our study as well. Any questions about anything else that's on this list? Something that surprises you?
I have a question regarding tobacco use and smoking. Does that include chewing tobacco, which is a major cancer?
So the question was, does use of tobacco and smoking include chewing tobacco because of the fact that it is known to be a dominant cause of oral cancer? It does indeed, yes, that includes that piece. It also includes Juul, this new vaping. They're trying to track vaping as well because very little is known. It's not showing that it's magical and non-cancer causing. So there's a lot, it's a huge new field of study. How it's being documented at this point, usually in data sets, they'll give it a little asterisk and say whether they've included vaping, is what the kids call it, right? Whether they've included vaping or not in their study. But that's a whole nother area that's a bit concerning. Did I answer your question?
Yes.
Other questions? Yes, ma'am.
What about teen births? Has that improved or not?
Her question was, what about teen births? Has that improved or not? It has, actually. It's improved dramatically over the last 10 years. We're seeing a lot of, I guess you'd say a lot of improvement in that space.
Do you have a reason for that?
Sure.
Is it use of contraceptives or less pressure kind of thing for young people? Or?
So the question was, is there a reason, do we know the reason and the data behind it, why our community has seen a reduction in teen births? Is it due to prophylaxis use or education or less stress in that space? This study doesn't look at that. The way we tie it together is we actually look at the public health spend in that space, both around health education, as well as access to prophylaxis at a younger age in that teen bracket. And the state of Indiana, as well as our own community, did spend more in that space and did more outreach. So I would say the two correlate. I don't know that I would say it's causative, but yeah, there's been improvement there. Part of it, especially for our community, is we can have all those materials available, but if they're only available in English, they only help some people. So I know there was a concerted effort over the last 5 years to make sure we have that education, that training communicated in native language. Yes, ma'am.
Combined comorbid health.
So the question was, what is combined/comorbid health issues? So what that is that is describing people who are chronically ill with multiple conditions. So I like to use my aunt, may she rest in peace, as my example there. She had COPD as well as congestive heart failure and diabetes and Parkinson's. That's a lot. So she would fall into that comorbid combined health issues. The healthcare of someone when they have multiple conditions like that, and they may be on multiple medications to manage them, then there's complexities amongst their medications as well. It is very hard to keep them healthy, and it's hard to make sure that they've got the right guardrails to keep themselves in their best self. So that is what that speaks to. When we look at, and there's some ALICE data in here about our elderly population, 90% of people over the age of 65 have one comorbidity, but around 50% have two or more. And that's where it gets difficult. Great question.
Would you speak to a lack of access to healthcare?
Absolutely. The question was, can I speak to lack of access to healthcare? So access to healthcare, and this is great. It's like you're leading me into the next couple of slides. Lack of access to healthcare is not as simple as a health system who employs doctors sometimes would like to believe. Simply having a building with a doctor in it that is nearby, that is not the same as access to healthcare. Access to healthcare is how many people in your community have insurance. Of that insurance, how much of it is high deductible, in which case they may have insurance, but they don't have the money to pay their part. How many people can't get together the paperwork or are unable to read well enough to complete the requirements for Medicaid filings. That happens a lot in this community. That's a big gap. And then we have people who are unpapered and are afraid to seek out healthcare unless it is a crisis because they have concerns that they might be forced to leave the country. So access it's a really interesting bucket that has a lot of pieces to it. Access can also be related to how the community perceives your need. And I'd say that related to mental health. If there's a stigma, you may have access, but you may choose not to use it. Is that fair? So since you were leading me through it, I'm going to move on because we're going to talk about that some more. So this is just a diagram of the way we prioritize health needs. That was a really big bucket. That was the entire bucket that you just saw on that slide. Okay, that's everything. So we don't work with everything. We need a priority list to give to our board, and this group creates that using this scaffolding. It's a peer-reviewed, published mechanism for how you value those needs. And here's another way to look at it in the way that's broken down. I like to pick out a couple of these pieces. So disparities within subgroups, I mentioned health equity earlier. If you know there is a dramatic difference in some of your subgroups in your community, that's a good place to dig in. You want to add more value there when you're prioritizing. Another item that is really important is the feasibility of intervention. Poverty was on that list. Can a health system change poverty? We can. We can do our part and we can work in that space. We probably can't fix it for an entire community, but we can try and be a leader in that space. Okay, so thinking through what's feasible is important when we go through this process. This is the list that the CAC came back with at the end of 2021 and asked our board to approve. So you're going to see, yep, it's only listed to 5, but there's 7 items. You might say, gosh, math is not your strong suit. Because of that prioritization process, we use scoring, it's numeric. So we had a couple of ties, just as a way to explain how that happened. Interestingly here, a couple of items I would pick out, and I would certainly ask Dr. Good to speak into this as well, having seen several of these go through over the years. Mental health, there's nothing really new on this list. This is I would say this is the archetypical list of challenges every community is struggling with today. But when you look at it longitudinally over time, mental health has never been number one since I've been here, at least at Goshen, and it was dominant this time around. So it's easy for us to look at this whole process and say, you're always going to get the same results. How do you know if you're moving the bar? Well, you don't always get the same results. And when something as seismic and dramatic as a pandemic hits, I would expect the order to change, and it did. So mental health was by far number one. It wasn't close. Diabetes treatment and prevention. We talked a little bit about how the Hispanic and Latino population is, they're definitely more concerned with it. It's a concern for everyone, but there's a disparity there, okay? We talked about how disparities are important when we look at our priorities. Poverty's never been on this list before. I do think part of the reason it's on here is because we're talking about it more openly now. We didn't used to. So I'd like to believe that we're all growing, but it also means it goes on the list. Obesity and weight management is tied to diabetes treatment and prevention. Lack of access to healthcare, again, is complex, something you have to dig through. Substance abuse and addiction, interesting. The occurrence rates and the trends for people being incarcerated for this and people self-reporting these behaviors dramatically increased during 2020. Is it because they were at home? We don't know. I suspect there's probably some correlation there. And then health education also being on the list. Anyone surprised by any of these? Do you have a question? So what did the health system do? The board did approve these priorities after looking at the process. We pushed them together here a little bit. And then a group of us, they approved in November, as it's footnoted. During the first quarter, the health system brought a variety of our team members together and also talked with more of our community partners and said, where do we think we can move the needle? Because we have to have an action plan that we share with the IRS and we report on. Okay, so you'll see I have these in different colors. We have a three-step action plan with a series of strategies under each. One in particular is focused on mental health. One is focused on obesity and weight management. And then the third is really trying to do more of a wraparound understanding of our community's needs and where we can impact them positively in the areas of poverty, lack of access, and health education. And we circled those three because they meet the definitions that the CDC uses for what's called social determinants of health. So these are aspects of your social environment that impact the health you have and your health outcomes. As a health provider, we want to understand that space and figure out how to work in it better to support our community. It doesn't mean we're always going to have the right tools, but the first thing we need to do is be serious about looking at it, okay, and not pretending it's not there. Dr. Troyer?
Diabetes treatment and prevention of poverty. Can you give us a number of, say a person has primary diabetes and needs insulin?
Mm-hmm.
What's that person going to have to pay to buy insulin for a year?
Okay, so the question was trying to scale the cost when you think about poverty and diabetes. What is the cost of insulin for a year? So what is happening right now, if you are on a basic insulin, I'm quoting Dr. Larry Allen here, so if my number sounds wrong and you know Dr. Allen, go get him. Yeah, I know you do. So the way we've talked about this, the cost of insulin, if you're not insured, is anywhere from $800 a month to $1,000 a month. Yes, it's high. If you're bare, if you don't have anything, number one, getting your hands on it's hard. Insulin's not always readily available, but it's exceptionally expensive. So it could certainly cost you anywhere from $9,000 to $12,000 a year. And that's, if you're living in Alice, if you're say you're at the 200% of poverty line, or you're making, even $15 an hour trying to support a family of 4, finding that money in your budget is impossible.
Is that related to the delivery systems that they have now, that they, supposed to be safer, easier, and so on? Or, I mean, if you have just a vial of insulin, it's going to cost that much?
Yes, and that is literally for a vial. Sorry, the question was, is it related to the systems of delivery, making it more expensive, or is it less expensive using older means? Is that a fair way to put your question? I would say at this point, the more advanced ways to manage insulin are like a continuous, it's called a CMG, like a pump. Those are very expensive and they have to be covered with insurance because the expense is when you first get them placed, then you refill them. The refills are less expensive. But if you're on a standard, if you can't afford to do something like that, or if that's not the right tool for you, and you're using an oral or an injectable, the costs have simply gone up. The technology is better. What they've done to create biosynthetic and non-synthetic insulin, the quality is quite good. You can become insulin resistant, I think is what they call it, or you're less resilient to it. Your body needs more and more of it. So that means your dosage goes up over time, which drives the cost up as well. So I don't know that we see a correlation between that. It's a good question, though. So I'll just walk through briefly what we're doing, and then I have a slide on other space that's really important that we aren't necessarily moving in. So around mental health, I think it's probably obvious to everyone here, everyone who's from this community, Oaklawn is our preeminent partner throughout our region for mental health support. There are others, but supporting our community here, Oaklawn has always been a wonderful partner. So several of our strategies are related to our relationship with Oaklawn. First is integrating primary care and community access enhancements. You may have heard that Oaklawn has moved to a crisis phone number system to engage both providers and individuals in the community who know that they are potentially in crisis and need assistance very quickly. You can't wait 6 to 12 weeks to get an appointment. Mental health doesn't work that way. So Oaklawn has been working very hard to get into that space. It's active now. They're still piloting it to a large degree, but Goshenell has pressed that out through to all of our provider groups and have told Oaklawn, we will support you in any way you need as you go through this change, because including giving them feedback from the providers and engaging in that dialogue so that we can help them support our community differently. This is a very different model for Oaklawn. So that's one of the strategies we have in place. We're also trying to bring inpatient mental health support to the hospital. Oaklawn does not have a bunch of extra providers who can be called down to help us support a patient who is in severe mental disorder or distress in the hospital setting, that they don't have that capacity. So we're looking at and investigating at least 2 other ways to bring that support in, because the volume of that, it doesn't happen horribly often, but we'll have 1 or 2 very significant cases a month. And we have a hospitalist team that works with our inpatients. They need help. This is not their specialty. So we need the availability of consult, both for those individuals, but also for their families if they're going to be discharged and sent home. Their families need tools that we are ill prepared to provide. So we're working to address that gap. Third strategy is really looking at building mental health education in the school systems along with our partners there. We've got a very robust community engagement department. We have built many bridges with different community partners that they've got the access points built. They just need content from the healthcare system to assist them in what's best practice, what's evidence-based practice for children, for adults, what's the right setting, how do we track education in that space. So we're helping them build that. That's something that we've had in place now for since the beginning of the year, quite honestly. We are specifically targeting both the Hispanic Latino community in their native language. We are working with their influencers in the community, so it's authentic. It's not a health system telling them something that's been translated into Spanish, because that is not the same. Okay, so we're using authentic voice in that space. We're also trying aggressively to get into the socially isolated, because they're the ones that suffer in silence when you think about mental health. They're already isolated and they're not well. So that's a challenge. So we've taken that on. Our 4th strategy here, Oaklawn actually received a large grant to create a crisis center here in Goshen. And one of the things they want to do is they want to be able to medically clear mental health patients to be able to go into a mental health facility at that space. Our current practice is they actually send mental health cases to our emergency room and we clear them there. And sometimes that can take 2 and 3 days, which means our ED has got people there that maybe shouldn't be there. They don't belong there. It's not best practice for the mental health patient. It doesn't really help Oaklawn. We're going to help them build what they need in their space so that they have more control over it. That's not their area of expertise. It's a hospital area of expertise, but we're going to work it together. That project was set to start next month, but we've had to push it back a little bit. They're not quite ready yet. So that's what we're doing in mental health. With obesity and nutrition, we've got a I may have mentioned this earlier. Lots of those community health needs have been health needs for a long time. The trend hasn't turned yet. Obesity certainly is one of them, and an understanding of nutrition. So we've got a very big platform in this space already. We want to continue to grow it and expand it and have it touch more people. So we've actually pursued a series of grants in this area. And the first item on here, we're waiting to hear for a state grant to expand the Goshen Community Garden. We want to put it in places that are known to be food deserts. We want to go out into the mobile home parks and build one there, so the people that live there and don't have transportation can still grow their own food. We want to train them in how to do it properly. So we want to take that model and make it more modular so it better suits our community's needs at their place of need, rather than asking them to come to us, because that doesn't work. Okay. Related to our collaboration with the school systems and Cultivate Culinary, this is amazing. You may have seen it in the news. The city of Goshen gave us a large part of a statewide grant support, and it's not, they didn't give it just to Goshen Health. We're not going to keep any of it. But it's for us, Cultivate Culinary, and the Purdue Extension to do more school backpack programs. So this sends healthy food home with students who have food insecurity throughout the community. It used to only go during the school year. We're going to be able, we do it now we do it all summer. It's awesome. And we are not just with Goshen Community Schools anymore. We've extended to 6 other community school organizations across our region. So we love this. This has been an amazing effort. And being able to push it further and touch more lives has been very, very exciting for us. And then we're also waiting to hear on a grant for the Regional Parks Department. We partnered with 9 of our regional parks groups. We want to invest grant monies into creating hardscape materials at each of those parks that take people through physical activity while they're there. You're already here. Here's what you can do to make your time here more physically challenging to help you grow. And that is actually a evidence-based practice that's been reported in the literature as being effective for a broader community impact around physical activity. So that's some of the other activities we've been doing. And then finally, looking at that social determinants of health piece, this is truly a space where we want to learn as a healthcare system. One of the key strategies we're doing first is we want to be going into people's homes after they're discharged. We don't always know what's going on in the home. The reason people may end up back in the emergency room may have less to do with their disease or their physical health. It may have to do with their property and what threats exist in their home. Okay, one of my favorite examples of this is some of our doctors may have a patient who needs to have a hip replaced. Okay, seems straightforward. Yes, go ahead, go see the orthopod. But if that person lives on the 4th floor of an apartment complex that doesn't have an elevator, maybe has some mental health challenges and is a hoarder and has stacks of materials around them and no family nearby and isn't attached to a church community for support, you could go ahead and replace their hip. They are not going to recover well. Okay, there are challenges there that aren't obvious. They're not obviously physical challenges. So we want to do different there. We want to go out, we want to send community health workers into people's homes and have them do an assessment and see if there's things they need. And how do we then refer that individual to other non-for-profits in our community that work in that space? I think of MDC Goldenrod, who I think, are they still around, right? Yeah, they're a wonderful non-for-profit, but they help people that have certain types of challenges in their home and get that around. We want to see if we can help. But first we have to know, what does it look like? So we're going to pilot that. We want to see what's going on. And our second strategy is that one's focused on inpatient. We already have in our outpatient space care coordinators who work with community members who have gaps. Okay. The challenge is they can only work with community members that have an insurance product that has a value-based care piece. It's just a technicality of how it works because that's how we pay for their salary. We want to expand that more broadly into our community to people who don't have insurance coverage. This comes back to our access point earlier. Access looks different all the time. How do we make access a little easier, right? But part of access sometimes is filling out your Medicaid paperwork and not speaking English or only being able to read at a 3rd grade level. So we want to bring our coordination services to a broader population. That's going to take some work. We're going to need to find some grant money there or some efficiencies, but we're dedicated to figuring this out. So those are our plans. It's not everything that was on that giant list. When I think about where the community could use more help, just in the work that I do daily and what I hear from my nurses who do home care and hospice, and my acute care coordinator nurses and my other executive colleagues. Transportation is the biggest hot button topic right now. And it's interesting because the Metro is currently doing their 10-year plan. If any of you take the Metro Transpo system, they've been in contact with us a few times asking us about what we need. I told them we need access to these small communities where people don't have cars. I'm not sure if they've heard me, but I've tried. We need transportation support. People they don't have families to pick them up and take them, or their families live too far away to support them routinely. They can't get to their appointments. They can't get to their employment places. It's a challenge. Home-based assistance is also an area that this community really needs more investment in and would be better supported with, whether that's pill counting by trained people for those that are maybe socially isolated and alone a lot of the time, just getting help, doing it safely. Evaluating the safety of their environment. I mentioned that's a part of our plan now, but seeing that done more broadly. There are some healthcare communities that have actually built volunteer workforces that go out into people's homes and do like a checklist just to try and figure out if they've got gaps and to work with that person as far as what kind of support might be available to them. So some of that's an opportunity. And the socially isolated is a big deal. There's more socially isolated than I think we realize. We all today are benefiting from a community of faith and a community of caring. There are a lot of people that live near us that don't have that benefit. Trying to identify who they are it's not easy. It's not natural if you already belong to a community of some type. So this is an interesting one. Trying to form community where there are those gaps, I think is an opportunity. And then a big piece, and I think again, Oaklawn is doing a tremendous job in trying to supply the resources around mental health, but we've got to destigmatize it. If you are having a hard time, things just don't feel right, we have to empower people to not hide it or act like I'm just having a bad day. We need to encourage them to, maybe you should talk to someone. Hey, there's access now. Maybe you should talk to someone. So those are opportunities I see. That's my material. I'm happy answering your questions, or if you guys want to have a debate, discussion. This has been a joy. Thank you for having me.
Any comments here yet before we break? We've taken advantage to use our normal amount of time. I recognize we're running tight for those of you who set your oven. No, it is regular time. Any more comments? Yes.
I have an observation. It seems to be that the areas that require more investment, more resources are some of the medically most difficult things in the world. I have a son-in-law who's a physician, and I've asked, have you ever helped anybody stop smoking? No. I mean, try,
Yeah.
And so altering those behaviors of what you eat or what you put in your mouth and what you lead on for a little relief from life's difficulties. I admire you for taking on the very difficult things.
Next also said admiration for medical people who attempt to change our bad behaviors. I think that was what he said. He said his son-in-law, he asked him, have you ever stopped someone from smoking? And the answer is pretty much no. This sounds like what I hear at board meetings when we get into some of these discussions. And the doctor members of the board say, you don't understand I can talk about all I want to in the office, and it doesn't necessarily change deep-rooted patterns of behavior. So you're correct. And I think you heard at least some of the efforts that are being made to deal with some of those pretty deep-seated patterns of community behavior. Any other comments?
I'm guessing there's a fairly large number of undocumented people
Yes.
in the community. And I have a feeling that it's very difficult to contact them.
Mhm.
They don't want to come out. What can we do with that?
The question was, living in a community where we have or we assume we have quite a large population of undocumented, they're difficult to communicate with, and what can we do? And it's because potentially they don't want to be found and communicated with, particularly around things like this. And what can we do about that? So you're absolutely correct. We do have a large population of undocumented. What's interesting is they are a community, however, and they are a very close-knit community at most times. So what we have done at Goshen Health, really trying to understand and meet that community where they are coming from, because that's usually the hard part. We think we know. This is a community that is not raised up the way that we have been raised up. And I'll share an example of that here in a moment. What we've done is we've actually spent the time, we worked actually with a number of folks here at Goshen College in this process. We went to a large number of different local media groups looking for a natural speaking, engaged influencer in that community. Because while they don't want to be communicated with, they do participate in social media, and they do participate in certain community functions and church functions that they are all tied to. So we've spent time and money and effort becoming authentic to that community so that we can be a safe space for them. And we find that that's been effective based on what we used to experience when we tried to engage with them and what happens today. So one of the type of event that we have for adult education is called Thrive. And we've done Thrive in Spanish. Nobody shows up. It's English translated into Spanish. It's not the same. So after having spent several years actually banging our head against that wall and engaging with this influencer, she gave us some recommendations. She said, don't have the event here, have it there, but don't do Zoom. They don't want to do Zoom. They're going to want to do it in person. And don't put it out on email, have flyers available and give it to the pastors of that community. I need to tell you, we had 75 people show up to an event that has never had more than 10. It was dramatically different, but we needed to understand how that community likes to be communicated with and what types of communication they trust before we could worry about our messaging. The messaging is secondary. First, we have to get past that initial point of trust. Is this safe for me? So when we were able to do that, it was good. But I mentioned that community wasn't raised up like us. And I was talking to a leader of a very large manufacturing company in the area recently. And she shared with me that 40% of their employees don't take their insurance. I asked her, gee, that's huge. Why not? She said, well, they all have to decide, am I going to spend $100 a month or $200 or $300 a month on something I may or may not use? And if they're immigrant into this community, into this country, they don't have insurance where they live. They have socialized medicine. It doesn't mean anything to them. They don't know what for us, if you've been in this, country, this community, this culture for, generations, we don't know what insurance is. Yeah, I got an insurance card. That doesn't exist there. So they look at it and they say, this is something I don't know what it is. You're telling me I may or may not use it, but I might need it in an emergency. Well, my family's in an emergency in the country I'm from, and I need to send them money every month. Many of them do. That's a hard call. Okay, and that's why access is challenging, because you want them to have that insurance. Their reasons to not carry it are valid. they're important to them. So I probably took that farther than you wanted. Sorry, that's what I'm passionate about.
The Center for Healing and Hope,
Mhm.
has that been a real asset to work? I mean, are you familiar with this?
Center for Healing and Hope has been an asset.
That
Yeah.
there's a lot of assistance to people.
So the question is, has the Center for Healing and Hope been a dramatic source of assistance? Because they do work with that community closely and provide a lot of resource. We partnered with them. Our most recent CFO is a board member. We share resources every chance we get. So I would say, yes, they are a tremendous asset. I need to say Maple City and Vista, they are an incredible asset in that community as well. And I know those two organizations work very closely together.
That's what I'm going to say.
Yes.
Let's give a thank you to Susan for giving us such a